And I really appreciate being invited to speak here. This is a great group. I don't know if you know how great you are. Just a wonderful curiosity, open-mindedness, and truthfulness. It's a pleasure. And I have spoken to this group twice before. This was in 2007 in Arizona. At any rate, mostly that talk was a general talk on Q with emphasis on periodontal disease. And then another occasion, this was in Tulsa in 2012, there was a lot of emphasis on the interaction between the cholesterol-lowering drug statins and Q on that talk. I'll review some of that in case some of you may have forgotten. But I was going to do something I don't usually do. I just wanted to present a very practical knowledge on how to use Q so that anybody in this room would have a working knowledge on what type of Q to take, how much, how to take it, and what to expect in the treatment of any degree of weakening of the heart muscle. It's a useful thing to be familiar with. Heart failure is increasingly prevalent, and if it doesn't affect you directly, it may affect a loved one. Briefly, the history of Q, it's fantastically interesting history, but in brief. I like this picture because the man in the middle, that's Fred Crane with his hands crossed and the big smile. He's one of these gentle giants, maybe the best biochemist I've ever met. He discovered Q. He actually discovered it in 1956, but he published it in 57. And he was working with a group, enzyme research group in Madison, Wisconsin. And they were trying to figure out how mitochondria worked. And so they were using beef heart, in Fred's words, a giant wearing blender, to blend up the hearts. And a third of the volume of a blended up heart is mitochondria, so they had a lot of mitochondria to study. And they knew something was missing, and they found an orange band on one of their separation columns. And Fred dutifully collected that. There's a little stopcock at the bottom, put it in a flask, and he stuck it in his refrigerator. And then he proceeded to spend the next several months studying every known carotenoid. I mean, it was orange, and they thought, well, maybe it's a carotenoid. None of those had any activity in their in vitro reaction setup. So he went back into his fridge, and it was crystal clear liquid. It had crystallized into beautiful orange crystals. And he thought, well, maybe these are something different. And sure enough, they had unique properties. That was published in 57. In 58, this man, Carl Folkers, this is an old picture of him, but I like it, obtained samples of these crystals, and it took him a year to determine the precise structure of Q. And this is interesting. The discovery of Q by Fred and then the interest that Carl Folkers had in it, from that time forward, it dominated their research efforts. Q is contagious. Anyway, this is a quote from Carl. In the early days, Carl Folkers wanted to call Q a vitamin. Well, since our cells can make it, strictly speaking, it's not. But it does have some similarities. Many vitamins are indeed coenzymes. Most people refer to it as vitamin-like. Carl Folkers met my father around 1980. Serendipity, maybe, coincidental. At any rate, they became very close friends and did collaborative research with Q ever since. Then I joined my father in 83, doing my fellowship, and I caught the Q virus. Anyway, this was the first controlled trial in the United States. I guess I'll tell this joke. I was not going to, but don't look at the slide. Just look up here at me. Okay, you start with both eyes open. These are how these studies are set up. Okay, if you cover one take one hand and cover one eye. That's a single blind study. If you take your left hand and cover the other one, that's a double blind study. If you cross your hands and cover them, well, that's the cat's meow. That is a double blind crossover trial. Just so you know. Anyway, so this was positive. It was just a 3-month treatment period. And what we wanted to know is, are these, sorry for the small font there, but would the improvements be sustained? We wanted to be sure Q wasn't acting like what we call a positive inotrope, like adrenaline. You know, you can get a brief increase in heart function with a variety of stimulant compounds that then everything falls apart later. So we followed about 120 patients for 6 years, and indeed the benefit was sustained. The name of Q, I've always loved the name Coenzyme Q10 because it's so descriptive. It is a coenzyme. The Q because it has a quinone, and the 10 because it has 10 isoprene units on its tail. The other thing great about this molecule is, despite a really significant effort, the modus operandi of pharmaceutical industry is, if you find a natural compound that has biological activity, you change it. You change it just even ever so slightly, a little methyl group here or there, and then you patent it as a drug. That's how it works. Well, they called these Q analogs, and it was at a dinner party, and they'd been doing this work for 15 years probably, and mostly in the Karolinska. And I had a talk with one of the key guys that was doing these Q analogs. And I said, well, did you ever get anywhere with any of those? And he said, well, all we did was make some really good rat poisons. This molecule is perfect, just like it is. And because it's not a pharmaceutical, there's some good things about that. Of course, there's a shortage of funding, but there's a little more honesty in what does come out. It's gotten to where pharmaceutical literature is just, it's borderline, or not borderline, it's absolutely fraudulent on one end of the spectrum. And it's just not trustworthy. It's gotten to be a mess. But at any rate, that's the oxidized form of Q. The ring, that's the quinone ring, and there's 10 of those little isoprenes. Most mammals are Q10. Rats, for some reason, have both Q9 and 10. Insects are Q9. And then yeast, they're usually shorter chain Q, like Q7 or 6. And then the reduced form of Q, some people call it the antioxidant form of Q, has these OH groups, ubiquinol. And they exist in a cycle. They're both essential, and I'll show you that. This diagram you've probably seen before, and I like it because it sort of sums this Q cycle up. These big blobs in the membrane, those are to depict enzymes. And when Q acts as a coenzyme, it gets reduced to ubiquinol. And then it finds itself in the vicinity of a lot of free radicals. Most of your free radicals are produced right here in this biochemical fire. And so it's immediately oxidized back to ubiquinone. So it's a beautiful cycle. And the end result of this, what you're doing is you're burning food with oxygen, and you create carbon dioxide and water and heat and free radicals. And then you create a proton gradient across this membrane, which drives the phosphorylation of adenosine diphosphate to triphosphate. So it's a beautiful system. One of the things not shown here, but I should mention it, mitochondria are primordial bacteria, so they have their own little DNA. It's a single-strand circular DNA, not well protected. And it's right at the heart of free radical production. So it gets damaged. And even in cells that no longer divide, like your heart or your neurons, the mitochondria do whatever they want. So if they had, a little damage to that, fragile single-strand circular DNA, the baby mitochondria usually do two things. One is they don't make ATP quite as well, and two, they make more free radicals. And it's believed to be, this is probably one of the fundamental aspects of aging. I just like this slide of Peter Mitchell. If there's ever someone who looked like they deserved a Nobel Prize, it's Peter Mitchell. And this is in the 70s, probably when the Nobel Prize still had meaning. The reason I showed this is just one of the enzymes that requires Q. This is huge. That spaghetti blob. That's a whole lot of effort. Those are big protein chains. And if you're low, and then Q is very, very small. You can't even see it on there, which is appropriate. It's small in comparison. Well, if you're low in a critical coenzyme, your cells downregulate the biosynthesis of these massive enzymes. And this is part of the delay with Q. If you're low in Q and you supplement it, it comes up in your blood and reaches a good level in 2 weeks. But as far as clinical changes, they're delayed for months. And part of it is it takes a while to upregulate and make these monsters. This may all be obvious, but anyway, ATP is required for all cell function. The heart is just the most violent organ there is. It uses just an extraordinary amount of energy. And this is important. Yeah, energy is required not only for the contraction of the heart, but it's a bit of a misnomer. It's called relaxation. But if you put your fingers together like this, and you just imagine that's actin and myosin. So when a muscle contracts, it gets shorter and a little wider. Well, that takes energy, but it also takes energy to pump calcium across membranes and allow this to uncouple. And if you want to think of the most dramatic visualization of this would be rigor mortis. When you shortly after you die, your dominant muscles stay contracted because it requires energy to uncouple that. So ATP is involved in both phases of the cardiac cycle. And if you improve Q, you get better ATP. Most of this talk is going to emphasize number one. It's central electron proton carrier for mitochondrial ATP. It has other functions. It is a meaningful fat soluble antioxidant. And I have friends in biochemistry and chemistry that have devoted their whole lives to some of these other dots. I'm not going to get into them, but there's more to it than I have the time to talk about. So this is where the practical information comes in. And it's amazing how many things you get wrong in the course of 40 years of studying anything. The key is just to embrace your mistakes, embrace your ignorance so you can learn. Anyway, I call it the Q effect. You're affecting all cells, not just the heart by any means. And so it doesn't lend itself to organ-specific thinking, and unfortunately, medicine is so subspecialized. There's some good to that, but when you're dealing with Q, you need to look at more broadly. And this surprised us early on. When we first we were studying what was termed idiopathic dilated cardiomyopathy. That's just a big, weak heart of unknown cause. And we were sort of hoping that maybe this would be like Caisson's disease. I don't know if you're familiar with that, but it's a province of China where dilated cardiomyopathy was unusually high prevalence. And no one knew the cause of it, and they just labeled it, it's just your bad luck, you grew up in Caisson. So at any rate, eventually it was related to the selenium in the soil, which was super low. And selenium is essential for normal mitochondrial function. But So we thought this would be around 1982 or 3. Maybe these dilated cardiomyopathy people would be low in Q, and if you just supplemented the Q to get a normal level, that'd be the end of the story. You'd be treating a deficiency state. It's not true. And more on that later. And again, the delay, as I mentioned. So what increases Q? Well, the number one is being young. You know, young people are endowed with a lot of cool stuff. And one of them is they make Q like crazy. And exercise, which is a big oxidative stress, intermittent is kind of key. It stimulates a young person to make way more Q. And it's one of the reasons you see Olympic athletes, gold medalists in their teens and 20s, not so much in their 30s and 40s. As you hit middle age, you can do everything right, train exactly the same, but people describe what's called hitting a wall, where they just never get faster. They just can't make Q like they could when they were 18. Now you can eat organ meats. Anything that works 24/7 has a lot of Q. And interestingly, now vegetarians, by the way, tend to be very well nourished. They don't get a lot of Q. There's some Q in plants. They have mitochondria. But the biosynthesis of Q is very complicated. It requires at least 7 different vitamins and minerals, and 2 in particular, folate and B6, tend to be fragile. So food storage and preparation can ding them up. And vegetarians in general get a lot of folate and B6, and they can have really pretty darn Q levels, even though they don't eat hearts and livers and things like that. But maybe I should have mentioned this. This is interesting. There was a time when Carl Folkers in Austin was not only measuring Q levels, but he decided to measure simultaneously with blood samples B6. And we would occasionally get young people, like college-age kids, that would present with irregular rhythms and fatigue. And of course, they had the usual college horrible diet, it's basically beer and pizza. At any rate, there were several cases that were fascinating. They had very, very low B6 and low Q, like low. And all we did was supplement them with B6. 100 milligrams a day is what I used at the time. And then waited 3 months and rechecked the B6 and the Q, and their Q darn near doubled just by normalizing their B6. So I thought it was pretty cool. And then taking supplemental Q. Now, the original Q, you had to extract it from beef heart, and it was super expensive. And it wasn't really available in any quantity to use in humans. So most of the early Q years were in vitro studies with tiny amounts of Q. The Japanese found a strain of yeast. Now most yeasts are a little shorter chain than Q10, but there are some that make the Q they use is identical to ours, Coenzyme Q10. So they can ferment the yeast, which produced a ton of Q, and then it's fairly simple, or at least I understand it to be not too complex, to get that to crystallize out. So the supplemental Q it's identical to what our own cells make, and the best comes from a yeast. And then happiness is an interesting phenomenon. I'll get to that on this slide. So what decreases Q? Getting older. Now you can burn the candle at both ends. There are young people who just relentless exertion or mental stress. And one example that comes to mind, it was dramatic. It was a grandson of a patient of mine. He just completed what they call Hell Week. It's the last week of training for Navy SEALs. I mean, you can imagine this is like as healthy as a person gets. Shortly after graduation, he flops over and he has a dilated cardiomyopathy. I suppose it's the same phenomenon as you can take a perfectly healthy 2-year-old hunting dog, if don't know what you're doing, you can run them to death. So you can overdo the exertion thing. overwhelming infections. The best blood levels that we had, that were they would drop by 50% with a really severe case of the flu. And in patients with heart disease, that often tipped them into overt heart failure. So bad infections, you can drop your Q. Of course, statins, and I'll get to that a little bit. But the sad pigeon story is fascinating. My first international Coenzyme Q meeting was actually in Tokyo. It was also the first time I'd been in an airplane. Odd story. But anyway, there was this great big, tall, probably 6'8" Swede. He might have been a Dane. But at any rate, he was a pigeon guy. He knew more about pigeons than anybody. And he had two groups of pigeons, and they were identical in terms of their activity, their diet, their light exposure. But one set, which he called the happy pigeons, he talked to. The others, he didn't. And they had a really significant difference in blood levels. The happy pigeons were much higher in Q. Anyway, it always fascinated me. I have no idea what that mechanism would be. This is a great, you could look at it as one of the most important enzymes in life, this reductase, and it's beautiful. It's like a butterfly. This is responsible for making a molecule called mevalonate, which is a precursor to a lot of things essential for life, cell division, important things. And you might wonder, why would anybody throw a monkey wrench in this? you would first think drug industry, right? Well, it actually was good old Mother Nature. There's 4 different species of fungi that they call them secondary metabolites. They're mycotoxins. They're secreted in the environment to kill competing life forms. Now, these are Amanita. These are not the really deadly ones. I should have taken a picture of the ones that grow in East Texas. They're completely white. And they're either called death caps, or my favorite name for them is the angel of death. One bite of a cap is enough to kill an average-sized adult. And the early statins came from one of 4 fungi, and then later there were some fully synthetic ones. Now this for some reason, reminds me of the mushrooms, like a femme fatale. This is a poster. It's not a great picture, but you get the idea. These are all statin tablets, and they're really beautiful in some ways. I mean, the colors and the shapes, it's very... Anyway, it reminded me of the mushroom. They're both mycotoxins. So anyway, these are the list of statins, and the one point to get off this slide is the first statin that Akira Endo, scientist in Japan, that he discovered was citrinin. Now, citrinin was ridiculously powerful. It was an irreversible inhibitor of the reductase enzyme. All the others are reversible. They're not irreversible. Well, Akira Endo wisely stuck that up on the shelf and looked for something less potent, and that became, you're going to like this, lovastatin. It actually comes from Aspergillus terreus. So can you imagine having your patient swallow something named that? Much better to use lovastatin. Anyway. And then there's many others. And the one on the very bottom there, the red yeast rice, the importance of that is that's sold over the counter. It's mostly essentially the same statin as lovastatin, but a third of the over-the-counter red yeast rice contains citrinin. So there's plenty of people who can die from the red yeast rice, and we've certainly seen people go into heart failure from it. It's just important to know that that's, when patients pick that up at a health food store, they wrongly assume it must be some natural, safe thing. It's not. This is just a diagram of that mevalonate pathway. So that black arrow on top, that's where our favorite enzyme, the butterfly one, is. Anyway, you block that, it's like chopping down a tree at the trunk. All the branches fall. And early on, like in the late 80s and 90s, most of our emphasis were on things we could easily measure, and that's cholesterol and Q. And then there were people who were dully cold people. But we did not have an appreciation at that time of how important these selenoproteins were in mitochondrial function. So we thought, and actually so did Merck, that if you added Q, you might prevent some of these statin adverse effects. And so this is 1989, and this is Nobel laureate Michael Brown and Merck. It was a patent to add coenzyme Q to statins. This one was to counteract myopathy. There was another one, I think, a year later that was for liver disease, but it doesn't work. These patents were never acted upon. There was never a combination product. But I put this study up there just because I can't believe it was published. The title alone is like nobody's going to publish that. At any rate, statins stimulate atherosclerosis. Really, they seem to stimulate coronary calcification. And this was written by a Japanese colleague of ours and us that we just love. But it's a fun paper. And if anyone that wants copies of these papers, some are for open access, some are not. But, we can certainly, if you just email us, we can get you a copy. With Mark Silver's a cardiologist up in Chicago, a good friend of mine, and we did a small study. We just demonstrated that even in people with completely normal hearts, as well as we could tell, on a relatively low dose of Lipitor, just 20 milligrams, within a few months, the majority of them developed moderate diastolic dysfunction. That in most of them, we could reduce it by adding Q. And then we did a much bigger study. This is open access, and it's worth reading. It's good. We called it SACM, statin-associated cardiomyopathy. And by the time we started this study, we knew that it didn't work just to add Q. You had to stop eating the mycotoxin, basically. You had to do both. And so we did both. Now, like I mentioned, there's an increasing prevalence of heart failure. Most of it they call heart failure with preserved EF. Now, at the time that we had this slide, 40% of heart failure patients are estimated to be on statins. I think it's higher than that, maybe over 50. And this is just to show you, the little blue box on the left, that's baseline Q level in these patients is 0.8. So it's a little low, not bad. Low is 0.3 or 0.4. So normal is 1 plus or minus 0.2. But at any rate, you stop their statin, put them on Q, and you get a good level. Our conclusions are fairly simple. One, SACM is, we think, quite common. It's clearly not recognized. Mostly, like 90% of the time, it presented with this preserved ejection fraction. We used to call that diastolic heart failure. And if you do two things, stop the statin and add Q, they do better. And contrary to pharmaceutical propaganda, they convince doctors and therefore patients that if they stop a statin, bad things are going to happen to them. They're going to have heart attacks or strokes. It's not true. You can now get Q levels pretty darn good just from commercial labs like Quest. Low is around 0.5, normal is around 1. Therapeutic is between 3 and 6, and I'll tell you why we think that might be the case. These are the reasons that maybe you need 3 times normal Q levels for it to work. You might need it that high to get an optimal tissue level. There's not enough simultaneous blood tissue level done anywhere in the world to be sure about that one. I sort of favor number 2. I think we're rescuing defective mitochondria. But there's other things. There's plasma membrane oxidoreductase. There's the glycolysis in the cytosol. Q can be involved in that. And interestingly, improving the red cell membrane deformability is a cool one. Red blood cells, maybe 9 micron diameter, a sphere? And it has to go through 5 micron capillaries. Well, the only way they can do that is they go through like a little noodle, like a hot dog, or they fold up like an umbrella. Well, they have to have a really flexible membrane to do that. Standard mindset. Oh, geez. Well, you go in to see a doctor and they tell you the bad news, you got heart failure. Their view of it is the treatment is palliative, it's never curative, they don't use that word. You're going to be stuck on some number of drugs forever. And there's terribly frightening things that are in your future, possibly implantable. We call them Mr. Sparkies. They've gotten better, but there was many years where those darn things would shock the stuffings out of you willy-nilly. So it's a dismal, diagnosis. Now this is what we do. If you have heart failure, we use 200 milligram soft gels. We have people chew them. That's like biting a big full wood tick. They pop in your mouth. There's no flavor to Q, but people absorb Q differently. We don't know why, so sometimes to get a good level, you have to go as high as 300 3 times a day. And there is a phenomenon, you just need to be aware of it, that Q is carried with LDL, along with vitamin E and beta-carotene, lycopene, of course, cholesterol. And there is an association between low cholesterol and worse heart failure outcome. But at any rate, just so you know, and then for formal studies, we measure not only Q level, but we also simultaneously measure the ratio of Q to total cholesterol to sort of correct for that a little bit. You don't really have to measure baseline Q. In studies you do, but since it's, they can get better even if the levels are, quote, normal. Now, treatment Q levels are handy because you assess the patient compliance, but also the quality of the Q supplement, and that can vary a lot. We had a good 25 years of just all Q, supplemental Q in the world, came out of 1 of 3 companies in Japan. They were all good. Now, like a lot of things, 80+% of the world's Q is made by a variety of companies in China. They're a mess. It's pooled. You don't know which city it's from. And we call them ghost peaks. We've analyzed. They don't say made in China on it, but it's the quality's bad. There's one remaining Japanese company still making Q, big plant down by Houston. And I'll get a little more to that. But they've been reliable. Now, the color of this Q is important. And sort of to keep these people honest, anytime you buy a new bottle of Q, you should take one of them, snip the end off, and squeeze out the contents and see what color it is. Good old oxidized Q, ubiquinone, was just a beautiful orange. If it were still made by the Japanese, it'd probably be my favorite because it's so stable. Ubiquinol, it is better absorbed, not as stable. So the soft gels are pretty thick. Either form works. Remember the Q cycle. Some people mistakenly call ubiquinol the active form. I mean, they're oxidized and reduced, both essential. If you cut it open and it's like a black goo that comes out, or if you taste it and it makes you throw up, it's bad. And Q doesn't play well with other things in the capsule for some reason, even things that you think would be good, like Q and fish oil. So it's better to get just a straight Q. My wife and I did this comparison study with healthy people, and ubiquinol is about twice as well absorbed. Now, in people with advanced heart failure, where they have a lot of abdominal, swelling, they're a mess, they don't absorb Q well at all. And the difference between ubiquinol in the advanced heart failure patients, that can be by as much as 4-fold. So that's the difference between it working and not working. So it's, the ubiquinol is, we pretty much have switched to that exclusively over the past number of years. Now, if you can't afford it, that happens. When we finished that 6-year study, we had over 100 patients at the end of that during the study, they received their Q straight from Japan. At the end of it, we had to find out what we could get over the counter, and it wasn't, you could get it in little 30 milligram tablets, at any rate. So we tried a pint of chicken hearts a week, and being in East Texas, people would just boil those up or just add them to their gumbo, and it worked really well, and it's cheap. Other organ meats would work. And then there's a lot more Q, the reason we chose birds. I don't know if you can see that, but on the far, what is it, your far right, that big tall purple peak, that's a bird. They're hyper, they have a high body temperature, high heart rates. They have a lot of Q in their hearts, high concentration. In the middle, that's a raccoon, it's sort of average mammal. And the little green thing on the very bottom, that's a snapping turtle. They have a very slow heart rate. And you just have to eat more turtle hearts to get your Q up. You could do it, but, okay. Is there any benefit to bumping it higher than 3? Well, the answer to that is sometimes, not in everybody. You can try it if things are falling apart, and this is an example of that. This is a patient from Houston. Now believe it or not, he was lower than this. His ejection fraction here is 20. Normal is 60. 10 is you're not going to make it very long. So he was 20, and he was on 300 AQ. Level was 2.4. Not really where we wanted it. But anyway, so he doubled his Q to 600, and he shoots up to 11. And this is over a 3-month period of time. And clinically, he's better, and his ejection fraction's now up to 40. So sometimes this is worth a try, bumping their level up. Now, we did take a number of really, really sick people and to see if there's any further improvement, like if you get these levels up to 17. We never saw that to be useful. Actually, getting it over 6 never seemed to have any beneficial effect on anybody. It didn't have any side effects, but it just got more expensive and it wasn't helpful. So what do you do if the level's not where you want it? Believe it or not, we insisted that patients bring in actually all their pill bottles and prescriptions, but one time I had a patient who was taking 200 milligrams of Q twice a day, not getting better at all. Checked his Q level, it was 1.2 or something. And I looked at his bottle, it was 200 micrograms of Q. So anyway, look at the bottles. You gotta be sure they're chewing them. If they don't like the wood tick sensation, they can cut them open and squeeze them out on a piece of bread and butter, but some kind of fat, they need to chew it up. It easily doubles your blood level, so it's worth doing. And of course, look at the color. And then sometimes you just change brands. These companies are all just a little different. And then if you need to, bump up the dose. So what to look for? So let's say you've got bad heart failure and you're going to start Q. Again, non-pharmaceutical mindset things. There's a delay, maximum improvements, easily 6 to 12 months. Now, when you have even a little bit of weakness to a heart, your body has some very powerful adaptive mechanisms. One's the renin-angiotensin system. So, and some of these you could call maladaptive. So these mechanisms can make the heart beat stronger, but they also increase blood pressure, which increases the workload on the heart, increase heart rate. You have less time for the filling phase. And so much of our pharmaceutical armamentarium for heart failure involves calming down some of these adaptive mechanisms. And so when you see someone with heart failure, they're going to be on these drugs, a number of them. And as their heart function improves, you have to anticipate that you're going to have to decrease some of these, because if you don't, they're going to faint because their pressure will get too low. This virtually always happens to some degree, so you have to follow people real carefully in the beginning to adjust these other drugs. And the other thing, and I got burned on this too, when someone has been in heart failure for months, there's a long list of things they really, really, really want to do that they haven't been able to do. So when they start feeling better after 6 weeks or so, they'll get out and clean out the garage and split firewood and weed whack or whatever, and the next day be in the hospital and, heart failure. So my analogy that I use with patients is I tell them, look, it's just like you broke your leg. Don't walk on it until it's had a chance to heal. So we try to sit on them for about 3 months. And then after that, exercise is great, don't get me wrong, but it's very, very powerful in many ways. So we began what intermittent exercise. What I mean by that is every other day or Monday, Wednesday, Friday. Sometimes you can't tell you really overdid it to the next day. But exercise does a lot of things. It puts people in better spirits, everything. And it stimulates your biosynthesis of Q. But once things get stabilized, we usually recheck their echocardiograms at 3 months, and then usually every 6 months until things are steady. Now, there's some things that just don't get better. If you permanently lost heart muscle, now akinetic means it doesn't move, dyskinetic means it bulges out the wrong way. Despite all the effort, and there's been plenty of it with stem cells, even where they inject them in the scarred areas of the heart, they haven't really made a lot of progress there. So if you've permanently lost heart muscle, you can't, at the moment, regenerate that. And many times, if people have been in heart failure for years, the heart, it's like a half-inflated leather football. It's thin, it's echo-dense. There's just not a whole lot of heart muscle there to improve. Okay, what does our great medical industrial complex have to say about Q? My wife calls it weaponized medicine. I think she's right. Commonly, they say, what's that? Or they say, I've heard of that, it's a waste of money. Or if you want to try it, go ahead. But they don't know, they can't tell you how much to take or what type or anything else. And this is actually kind of sad. I mean, for a compound this straightforward, discovered in the 50s, for 99% of physicians coming out of training to not know anything about it, it's not healthy. I mean, medical education is clearly wedded to the pharmaceutical industry, and it was not always that way. It is now. Okay, and I thought I should mention this. I haven't seen a lot of it, but some. Heart failure secondary to these darn shots. This whole shot thing's a mess, but at any rate, about all I've seen, if you add Q to the messenger RNA damaged people, you can improve some of their fatigue, and heart function can improve. A lot of things clearly don't ever improve. You can't improve the autoimmune process. And the clotting problem, that's, of course, Q has no role there. But when I was preparing for this talk, it was kind of odd. I thought, there's some similarities between statins and these darn shots. And one of them was they're both aggressively, and I mean with reckless abandon, prescribed in the old, in the young, and they're continuing to be used despite adverse effects, and both are, of course, supported by relentless propaganda. And the adverse effects are kind of odd too. You know, they're multi-organ. The one thing that never happens with statins, you don't get those darn clots. But there's some similarities. I think the shots are worse. One of the worst things about statins is that insidious onset. You know, if you gradually are getting weaker and gradually losing your noodle from something you started years ago, it's hard to relate. You know, most drugs have the decency to give you side effects pretty quick. You take something that makes you throw up, you stop taking it. So, but at any rate, so this nearing the end here. My personal thoughts on these darn shots. You know, before they came out, I read the animal studies, and one of them really disturbed me. It was a study on ferrets. Well, they gave the ferrets the messenger RNA shot. They waited some length of time, then they sprayed them with a virus, coronavirus. Well, it killed 100% of them. And I mean violently, bad, hemorrhagic. Not that many things kill 100% of your lab animals. It was disturbing. So I didn't recommend these from the get-go, just based on what I could read before they came out. But my mindset on these things was, it's just your standard drug industry. They're doing what they always do. But I started to look at it differently in the last year. You know, big pharma, you expect them to, everything is always new and improved, right? They minimize adverse effects, they exaggerate benefits. It's what they do. But they don't normally exterminate their customer base. That, and if they've ever done that in the past, maybe they have, but I didn't catch it. And so maybe it is a Department of Defense, you know, other people know much more about that than I do. And, you know, I've known that there are people that are convinced that if you depopulate humans enough, the world will be a better place. But, you know, I just never thought in my lifetime I'd see something like this. And I think it sort of looks like that may be the case. So anyway, so what are the consequences of these darn shots? I was trying to think of a good adjective for the toxic part. For me, they're unimaginably toxic. I have a good imagination, and I would never have guessed we'd be seeing what we're seeing now. And, you know, there's been a gradual loss of trust in the medical profession now for 20 years, but I think this is complete loss. Who, with a thinking head, would believe safe and effective? And nobody, right? It's not possible. And noncompliance, which I've always viewed as at least a survival advantage, I think it's actually essential for survival now. And do your best to avoid doctors. You can't always do that. Anyway, Carl Folkers used to say this all the time. Never, ever, ever give up. And this is my ending picture. I didn't have a picture of Dallas, but this is East Texas. That's off our back porch. So there's always beautiful hope in, you know, all the magic of life and love and good things. And I'll end it there, and thank you very much for your attention.